So I'd like to now introduce Dr. Vidya Raj. Vidya was born and bred in the UK and completed medical school at the University of Manchester. After marrying her Canadian husband, who we heard from this morning, she moved to Nashville and completed her residency in psychiatry and fellowship in psychosomatic medicine at Vanderbilt University. She moved to Calgary in 2014, where she is an assistant professor of psychiatry and cardiac sciences at the University of Calgary. She is the director of the Calgary Hearts and Minds Clinic, which she founded in September 2016. Dr. Raj's clinical areas of expertise include conversion disorders, mood disorders, and the psychiatric management of patients with POTS and heart disease. She often collaborates on clinical research projects with her husband, Dr. Satish Raj, who's an electrophysiologist and researcher we heard from this morning, who's interested in studying human physiology in patients with autonomic dysfunction. So changing tack this afternoon, Dr. Vidya Raj will be speaking to us about untangling dysautonomia and anxiety. Thank you.
Good afternoon, everyone. It's a pleasure to be here. Thank you for that kind introduction. All right, so the topic of conversation today is a bit more scientific, hopefully, than yesterday. It's actually the question of how to actually disentangle dysautonomia from anxiety. Bit of a mouthful there. I don't have any relevant disclosures to make regarding this presentation. So back in 2008, when I was significantly younger, I was actually working as a research fellow at Vanderbilt University, which, as you know, has a very large program that treats and assesses and does clinical research on patients with POTS. There was a lot of hearsay that kind of repeatedly we heard. These patients are more anxious than the average people, and so much so that we actually sought to have a look at this in terms of research. So the first question that we wanted to answer was, do POTS patients in fact have an increased prevalence of psychiatric illness compared with the general population? So we went in with the null hypothesis that we don't think that they do. In order to answer this question, we recruited 3 different subject groups. Patients with POTS who were undergoing research on the General Clinical Research Center. We closely matched them with psychiatrically normal, healthy control subjects. These are basically university students who volunteer for research studies. We then recruited another 18 patients from the ADHD clinic. And we gave them a very detailed questionnaire called the SCID-1, which in detail will actually diagnose any Axis 1 psychiatric disorder possible. So they went through some very thorough interviewing, and were also asked to complete a bunch of different self-reported questionnaires. They focused on depression. There are 2 there that focused on anxiety, which I'll explain in a bit more detail later on why we did that. And then we also, as an aside, did some measures of ADHD to look at cognitive function, which is less relevant to this particular talk, but is mentioned there. So here are the basic demographics of the population. So who was it that we studied? The patients with POTS, as you know, were very closely matched with the normal controls, so were very heavily female skewed, and had a very similar kind of age range there. It's really the patients with ADHD that drive the p-value that's different, which is they will be more likely to be much more equal in terms of gender distribution, male and female, which you see there. The race was very heavily identified as Caucasian here. And education level was really very similar. It was slightly more, although not statistically significantly so, in the patients who were the normal healthy controls because they were enrolled from the university population. So first set of results. What you see here is the results of that detailed diagnostic interview looking for actual diagnosable Axis 1 psychiatric disorders. So we have major depression, generally anxiety disorders, specifically panic disorder, and then substance abuse or dependence. I grant you that our populations were really small, which is really typical of research in POTS patients. But from what we can see, if you compare with a very large, again, US-based background population, that's the first column there that you see. Ron Kessler and his group repeat this across the US population by a survey every 5 years. Huge number of patients. And what you can see there is that, look at the POTS column. It's actually really quite similar, despite the small number of sample size, to the population background. Specifically, major depression, 17% compared with 19%. Anxiety disorders, you've got 29% in the general population, you've got 33% in patients with POTS. So either the same, I mean, maybe you can really convince me it's slightly more, I'm not quite sure about that. Panic disorder, exactly the same. And patients with POTS, much less likely to use substances compared with the general US population there. If you look at the ADHD group, you'll actually see what is really familiar to us in mental health, where across the board there is a higher comorbidity of pretty much the majority of psychiatric illness. The bottom particularly so, substance use. We think that's actually to self-treat often. Okay, so the conclusion there is, no, we're not really convinced that patients with POTS have a higher rate of psychiatric disorders in general than the background population. So question 2 we sought to answer then, specifically about anxiety. So are POTS patients more anxious or anxious at all? So the second part of the study, as I mentioned, was involving a lot of self-rated questionnaires. So this one is called the Beck Anxiety Inventory. It is a very traditional type of anxiety questionnaire. Okay, so it's very widely used, and it's really good at discriminating between normal anxiety and depression. It will exclude depression, so it's very good at measuring anxiety. But here's the issue. If you look at the questions on this kind of measure and traditional measures of anxiety, you can actually differentiate them into 2 specific factors. So the symptoms you are asking people to rate will boil down to 2 different domains. One is called somatic anxiety, and the other is cognitive anxiety, which I had touched on yesterday, but we'll talk about in more detail. Okay, that aside, if you use the BAI, these are the results you get across those 3 patient groups, and compared on the right with a large background panic disorder population that the questionnaire was actually validated on. What I hope strikes you is that patients with POTS are up there, right, in anxiety. They are scoring in the moderate category, only a little bit below panic disorder, right, which is severe anxiety. Our normal controls, the university population, I don't think they're working hard enough. They are not very stressed. Ignore that. But the ADHD patients, mild anxiety. Okay. All right. Moving on. So here's the fundamental problem with using that kind of questionnaire in patients with POTS. It's measuring those 2 factors. So the first on the left, the kind of symptoms I can ask you, and you can tell me I can feel these things, right, at a mental level. Are you feeling nervous? Are you unable to relax? Maybe so. Are you fearing losing control? These are things that you can rate at a cognitive level. On the right is the second factor, which are somatic anxiety symptoms. And they are largely found in a flight and fight response in folks who have panic disorder. So those kind of, have a look at those. I feel faint or lightheaded. My heart is pounding or racing. I feel unsteady. And I hope that it's apparent to you or anyone who has POTS or knows someone with POTS that those are pretty much symptoms of POTS. So the question that arises then is, on these anxiety measures, what are you measuring? Right? You're not actually just measuring anxiety in patients with POTS. You're also measuring POTS symptoms as well. And it won't surprise you then that the prior questionnaire, the data I showed you, is artificially elevated, and we can actually prove this. If you use a measure that is strongly focused only on cognitive aspects of anxiety, and this one is actually now the most commonly used, I would say, in POTS research, the anxiety sensitivity inventory that largely excludes the somatic symptoms, guess what you see? Okay, slightly different looking graph, right? Vastly different. You've got POTS patients now at the level of like ADHD who had mild anxiety, pretty much. Panic disorder, like completely different population. POTS much less anxious than those with panic disorder. They were almost the same in the previous slide. And the background general population, if you just compare, POTS patients are about similar in terms of anxiety level generally as the background population, a US population here again. Okay. So other groups have looked at this from the exact opposite direction. So they've asked the question, is a physiological measure in POTS, a physiological symptom, due to blood pooling, or is it actually due to anxiety? And the question asked then is, let's look at heart rate. Is it due to blood pooling effect or an anxiety effect? So look at it in that direction, if I haven't quite convinced you yet. So we have a lovely experiment with a pair of like inflatable pants and a vacuum cleaner here, but it really is very, very elegant. It was done in 2006, and it's actually a very elegant physiological experiment, and I'm going to present it in 3 different parts. See, so in this study, Masuki and their group examined the relationship between orthostatic tachycardia and anxiety, and they compared POTS subjects and healthy subjects. So what they did was they brought these patients onto the unit and applied this true lower body negative pressure, like basically a vacuum pump that simulates what it is to stand up, like it basically sucks blood from your bottom, lower part downwards. So that will create orthostatic stress. There are then 2 control conditions, the 2 parts on the right part of the slide. Those are controls, and what you do there is you apply the lower body negative pressure, but then you inflate these anti-shock trousers, these great big trousers, to actually negate that effect. So you're not actually creating lower body negative pressure. And the third condition is you just apply a vacuum pump without any lower body negative pressure. So it sounds god-awful, it's really loud, but there's actually no pressure being applied there. So I think just look at the upper left part of the slide, and the most important point there is there. The top line you have POTS patients. Really, heart rate, I think you can see, is only convincingly increased in patients with POTS when there's true orthostatic stress present. It's not present in any of the other conditions. Okay? So the conclusion from this part of the study was that the tachycardia in POTS is induced by true orthostatic stress, right? Just simple. Next part of the study, this time they're going to produce a different kind of stress, not orthostatic, but mental stress, using, if any of you have sadly been subjected to this, what's called the color Stroop word test. Yeah, so somebody knows what I'm talking about. But stressful, like not much fun to do. So the patients with POTS and controls were subjected to this, and hopefully you can see, looking at again, just the left side, look at the left upper part, the heart rate there. Patients with POTS are at the top, but controls are just underneath. Virtually the same line there, right? There really isn't any convincing difference. So the conclusion there is that heart rate responses specifically to mental stress are very similar in POTS patients and controls. Okay. All right. Finally, so this starts to look at a different aspect. So what is the nature of anxiety? And we're going to get into that. Patients with POTS and the controls were also asked to complete some self-rated questionnaires there. The Anxiety Sensitivity Index is a measure of anxiety-related body sensations. Okay. The next one, somatic vigilance, will actually assess how much someone is focusing on internal body sensations. And the third one is called catastrophic cognitions. These are like their thoughts of helplessness or feeling like you're unable to cope with your symptoms. It will not surprise you, I'm sure, based on that description, that POTS patients scored significantly higher than controls on those measures. Okay, so, but very, very specific types of anxiety are being asked about there. Incidentally, those scores are actually just above the upper limit of normal in a general larger population, but significantly less than in panic disorder. Okay, So, okay, I've said basically the point that generally anxiety isn't specifically elevated in patients with POTS, just generally. But what type of anxiety is really the question addressed by this next study by Fisher and colleagues. So, yeah, there's anxiety, but what is it? So 58 subjects with POTS, again, were recruited and completed a bunch of self-rated questionnaires, including the ASI, but also scores that measured the level of somatization, which is preoccupation with internal bodily symptoms. Then anxiety generally, and then specifically the somatic and cognitive aspects of it. And this, they also they obtained a level of the burden of autonomic symptoms a patient felt using the Compass 31, a commonly used scale to measure autonomic burden. Like in a nutshell, they basically found that generalized anxiety symptoms, the general background symptoms, weren't remarkably high, which we've also found. But specifically what is elevated is fear of arousal-associated symptoms and somatization. So what does that mean? That means POTS patients are only really specifically anxious, focused on their level of internal symptoms, internal physical symptoms. So the next study asks what specific physical symptoms elicit this kind of anxiety. And you can see there in red that the study basically says it's cardiac symptoms. This is what is being internally monitored by patients with POTS and leads to anxiety. The task is how to manage those symptoms. So in conclusion, those findings have been repeated actually across many other studies. And it suggests that patients are interpreting autonomic symptoms as threatening, okay, at least at the beginning, before they learn kind of how to cope with them. What that does is it actually gives a very specific role of psychotherapy, not generally, but what you want to do is actually help people reframe their perception of autonomic symptoms, learn to live with them, and change that feeling that they're threatening to something that they can manage emotionally and behaviorally. There are, sadly, just before I came to this conference, I had a look at the state of the literature to see what psychological treatment studies actually exist in POTS. There are only 2 that I can find. If anyone finds more, please find me at the end of the talk. So they're both done in adolescent POTS populations. So the first one here is done by the Mayo Group, and they recruited 33 adolescent patients with POTS between ages 11 and 13. The patients were asked to complete disability, depression, and symptom catastrophizing ratings, both before and after going through this treatment program. And both kind of the strength, what's nice about the study, but also what's really difficult to interpret what's beneficial, is that it's called a 3-week intensive outpatient CBT program, but has a lot of different modalities actually involved in it. So it was pretty intense. They got basically physical therapy, occupational therapy, recreational therapy. I can keep going on, I'm going to get exhausted, right? Biofeedback, stress management, healthy lifestyle training, pain and physical symptom management. Now, all probably are helpful, but you tell me which of these is more helpful or what is actually helping here, right? I don't know. So kind of not surprisingly, everyone got a lot better. The beginning, the adolescents are saying their functional disability score is moderate. It's half to minimal by the end of the study. 56% said they were severely depressed at the end of the study. That's gone down to 9%. I mean, it's like an amazing study, isn't it? And then catastrophizing has halved, and that's a negative mindset linked to increased disability. So, sorry, I don't mean to be too cheeky about it, but I'm not quite sure what to make of that. The second study here actually does a comparison of 2 different things, which is a bit more helpful. So you've got a mindfulness-based stress reduction intervention compared with group support. So what do I mean by that? So mindfulness-based stress reduction involves specific modalities, deep breathing, guided imagery, yoga, meditation, and then the group was actually allowed to discuss how they cope with stresses. So that's the specific intervention. Kind of almost the control group is the video support group. In this one, a leader just facilitates a group discussion, generally about cardiac health. And then this is followed by a discussion amongst the members of any particular topics of interest. Okay, often that was about how they're coping with their illness. So in this study, 46 teens were recruited. All of them had some kind of cardiac illness, but 48% of that group had POTS. Patients were then randomized to receive 6 sessions of the mindfulness treatment or 6 sessions of video online support. In the POTS subgroup, 14 received mindfulness, 10 received online support, and they all completed a self-rated questionnaires at the beginning to measure levels of anxiety, depression, how stressed they were, and how well they felt they were coping with their illness. Okay, so here are the results. Interesting results, right? You'd think that anxiety, depression would change significantly, certainly compared with that last study. They don't a lot. But what does improve is a patient's feeling that they are less stressed and they feel more able to cope with their illness. Okay? Interestingly, you get very similar improvements in those scores, whether you got mindfulness or whether you got video online support. Okay? So the conclusion really is that patients would say this, there's some benefit in being with others like them, right? I don't know what that bit is. Is it learning to live with things? Is it feeling that you're supported or you have a community? These things are important. The qualitative part of this study actually asked patients to say what they thought helped them. The only particular benefit above and beyond video online support in the mindfulness group was that patients in the mindfulness group actually said they felt they learned new strategies to manage their issues, nervousness, or a cardiac symptom. Right? So maybe that's a little bit of an edge. Okay, I will just make some conclusions at this point. So just to recap, patients with POTS, we have found, do not have an increase in prevalence of Axis I psychiatric disorders compared with the general population. They do have elevated anxiety on general traditional measures of anxiety, but not when you actually use cognitive measures, okay? And that's an artifact of the fact that POTS symptoms will overlap with somatic anxiety measures. Physiological studies looking at it the other way have actually confirmed that heart rate elevations in POTS are related to the orthostatic challenge rather than anxiety. Okay. And the latest studies suggest that anxiety in patients with POTS is specifically focused on fear of arousal-associated symptoms, particularly cardiac. And this leads to a role not just for blanket psychotherapy, but specifically in helping patients live with symptoms and reframe their perception of the autonomic symptoms and keep going in life. Okay. Thank you very much.
Thank you very much for an excellent presentation, Dr. Raj. So a couple of questions that have come through. I mean, the study that has shown the greatest benefit is a 3-week intensive program, probably unrealistic for most of us to achieve that. In your clinical practice, at this point in time, are you using psychotherapy? Do you have, any clinical experience in that being helpful in reframing perception of autonomic symptoms? Or are there studies going on that we can look forward to the outcome of to guide us further with this?
Gosh, I'm going to disappoint you. I don't know of any studies. There really hasn't been much done, and I'm not sure why. Yeah. Right? It's disappointing after all this time when we originally started looking at this in 2008 that there are 2 studies.
Yeah, absolutely.
Right? Do I use these techniques? Yeah, I think, and I have a colleague called Morwenna Opie who's a psychologist who treats POTS in the UK, who's written a lot about this, but a lot of it is cognitive behavioral techniques specifically focused on what are my symptoms? How do I recognize when I'm having a bad day? What is my action plan when that happens? So it's a lot of learning and getting confident in how to manage things, right? And through that process, then you have a certain degree of confidence that I am able to manage what I have to manage. And following that, people will start to regain their lives and function and be able to move forward in life. But it's not until that point. They have to gain a certain confidence.
Yeah, absolutely. A couple of questions around the role, do you think there's a role for anxiolytics, CBD oil? is there any particular pharmacotherapy that you think is ever useful in this situation?
Yeah, it can be. I mean, patients with POTS can have anxiety disorders and depression. It's not like they don't, but it needs to be specifically diagnosed and distinguished from POTS symptoms, right? That requires an actual proper evaluation. So people can go through depression, anxiety, particularly as they learn to. The beginning stages are really difficult, particularly.
Yeah.
So I can and do use pharmacotherapy. There isn't any evidence-based treatment at this point. We tend to prefer to use SSRIs just because, I mean, you've heard from other presenters that SNRIs or anything that boosts norepinephrine can be associated with worsening of POTS symptoms. So we try to stick with a simple antidepressant. Although benzos are not appreciated because they have a lot of side effects, they are quite well tolerated in patients with cardiac disease in general. And POTS, and can help, particularly short-term, for significant anxiety or just sort of PRN use. But this is all clinical experience, and none of this is like, there's no evidence base at this point.
No, we're really lacking in an evidence base at this point in time to guide us, and I think that's probably one of the, the challenges that we are facing right now. Okay, please join me in thanking Dr. Raj and